Assessment of the medical chart. This talk really goes hand in hand with the patient evaluation talk because every single time a patient is under our care, we need to make sure that we've done everything to ensure their safety and their health while they're with us. And so, not only is it evaluating their condition upon arrival and routinely throughout the night while they're in our care, but also doing our due diligence in evaluating their past medical history and how we can tailor our testing and our care to every patient's individual and specific needs. So, I'm going to start by giving a little background on why we do what we do. In terms of sleepiness, the average adult needs about 8 hours of sleep, but only a little over a third of Americans receive that much. It's a issue, and a lot of it is because of our lifestyle. We are going to bed too late, getting up too early, spending too much time on our cell phones, when we should be trying to go to sleep, playing one more game, checking social media, all of that, and not giving sleep the priority that it deserves. We need sleep to survive. There's been plenty of sleep deprivation experiments, not a lot done on humans because for obvious reasons, but they have shown that sleep is a necessity. Just it's a basic need. So Betty White just actually celebrated a birthday. She's 99 years old now, but she gets it. You don't live that long if you're not getting an adequate night's sleep most nights of the week. So, sleepiness, like I said before, reflects an unmet need. It is a basic human drive, the need for sleep. So, just like when you're thirsty, thirst demonstrates dehydration, the need for liquids. Hunger represents an unmet need of the need for nutrition. Sleepiness reflects an unmet need for the need for sleep. It is necessary to our normal, healthy functioning and for our survival and our just overall well-being and health. So, in terms of what can happen when someone is tired, there's a lot of different effects that sleepiness can have. Some people are able to kind of withstand the effects of sleepiness a little bit better. Other people are more susceptible to being tired. We're all different in terms of our tolerance levels for how much sleep deprivation we can tolerate. But what you might find is falling asleep in inappropriate places, inappropriate circumstances. So, watching a lecture on a public transportation, something like that. Feeling fatigued during the daytime when someone should feel most awake and alert. Morning headaches are a common issue. Inability to concentrate, remain alert, impairment of your motor skills and cognition. So, a sleepy driver is more at risk behind the wheel. They've done studies. A tired driver can be more dangerous than an inebriated or a drunk driver. Just listlessness, not wanting to do much, compromising a lot of the different daytime functions. There's a lot more increased risk of car and work accidents. I've had plenty of patients that have either lost their job or on the brink of losing their job because of their inability to stay awake or their inability to perform their job duties because of sleepiness. Disruptive family life. So, when you're tired or when you're not feeling well, you tend to take it out on those that are closest to you. And that can include your family. Dysphoria, which is an emotional state marked by anxiety, restlessness, or feeling unwell. Less ability to cope with stress, more irritable, less efficient. I mean, when you're tired, all aspects of your life can be impacted, and it seems kind of commonsensical when I just say, when you're tired, how does it affect you? But I know, when you get a good night's sleep, you could feel a lot better tackling your day and all the stresses that the day might bring when you have a full 8 hours backing you going into that day. Other impacts are impaired memory because memories are formed during sleep. Oftentimes the memories transition from short-term to long-term during sleep. You can feel nauseous, dizzy when you get really overtired, overeating. So when you're tired, your body tends to crave carbs and sugars to kind of get that immediate burst of energy. So you can overeat to try to make yourself feel better, to give yourself a sense of having some energy when it's not really great for the long term. If somebody has ADD, ADHD, there's been plenty of studies that show that sleepiness can worsen. On a side note on ADD, ADHD, one of the things that I'll point out is when children are tired, sleepiness tends to manifest itself differently in kids, whereas in adults, it's pretty obvious when we're tired and we're able to communicate that we're tired. This slowed down, head nodding, the eye drooping, whatever. With children, it tends to go opposite, where they can get actually hyperactive, and that's because of the release of the stress hormone cortisol. When a child is sleep deprived or overtired, that stress hormone gets released, and it's actually an excitatory neurotransmitter, so it can create that over excitation in kids. So there's been plenty of instances in my career where I've seen kids get diagnosed as having ADD or ADHD when they actually had an untreated sleep disorder. And once the sleep disorder was treated, their behavior issues significantly improved. Reaction time, moodiness, aggressive, just overall decreased quality of life. Because again, when you're tired, it can impact all aspects of your life. They have done studies in terms of the impairment that sleepiness can cause, and they've found that 19 hours of wakefulness induces impairment equivalent to a blood alcohol concentration of 0.05, which is actually under the legal limit of alcohol, but 24 hours of wakefulness induces impairment to that of a BAC of 0.10, which is actually over the legal limit. In New York, the legal BAC limit is 0.08. So, like I said, a tired driver behind the wheel can be more dangerous than somebody that is under the influence. A lot of fatal accidents that occur. I think the New York State Thruway Authority estimates that about a third of all fatal accidents that occur on the thruway occur because of a driver-related sleepiness. When somebody is under the influence of a drug or alcohol behind the wheel, there's at least some kind of reaction, although it's very impaired. When somebody falls asleep behind the wheel, there's no attempt to correct the vehicle. There's no response at all in these people. So that's why they can be so fatal and so disastrous. One of the most dangerous drivers behind the wheel is somebody that's tired and has a drink, because alcohol has more amplified impact on somebody that's overtired or sleep deprived. And even though their BAC may not be past the legal limit, their levels of impairment are significantly altered. In terms of behavioral signs of sleepiness, you can see somebody yawning, they don't move as much, lapses in attention, their head starts to drop down, their eyelids can start to drop. It's all the kind of the commonsensical stuff. Listen to me for any length of time, and then you just got to look around the classroom or look at yourself, and you'll see the behavioral signs of sleepiness. But there's a lot of different things that can decrease the behavioral manifestations of sleepiness, like motivation. So if you're motivated to stay awake, you're motivated to listen to a talk, you're motivated to watch a movie, if you're being stimulated, if you're playing a game, you're involved in a conversation, something like that, competing needs, hunger, thirst, anything like that. So, like I said, everybody has different susceptibilities to sleepiness. Some people are able to kind of withhold it a little bit better than others. Some people are, just modest sleep deprivation. They really feel the effects of it. So everybody has their own tolerance levels. Modest sleep deprivation can accumulate over time and progressively increase daytime sleepiness. So that means that, say, you only slept 6 hours one night, kind of same thing happened the next night, and it kind of went on like that. You're going to feel the sleep deprivation continue to grow as the week or the days go on. Generally, though, most people that are sleep deprived, they're able to alleviate their sleep deprivation by 1 to 2 nights of good quality sleep. And so that's one of the great things about sleep deprivation is it's easily correctable, for the most part, when it's caused, especially if it's caused by behavior or anything like that. But what you don't want to see is, somebody that creates this modest level of sleep deprivation throughout the week by limiting their sleep time, limiting their time in bed, going to bed late, having to wake up early for the week for work, and then on the weekend, they oversleep and overshoot it and kind of make up for the sleep deprivation that they created during the week. That's not really a healthy habit to get into. But for the most part, they're able to somewhat recover from the sleep deprivation that they've built from the week of, or long days, late nights, early mornings. So, chronic sleep deprivation is the lack of necessary sleep over a long period of time. That's something that somebody can have for a long, months, years on end. So, these are the patients that we see that have a sleep disorder. They oftentimes, when people have sleep issues, it's not something that happens overnight where all of a sudden they've got it. It's usually something that slowly comes on and gets worse and worse and worse until it eventually gets to the point that that kind of kicks them in the butt to come into the sleep lab and figure out what's going on and see if they can't get treatment for their sleep issue. Sleep debt is the amount of sleep a person has lost over a period of time with what they should receive. So say somebody pulled an all-nighter, they have now accumulated a sleep debt of 8 hours because maybe they went 24 hours without sleeping. Well, within a 24-hour period, you should sleep around 8 hours as a normal adult. And so our patients, though, when we look at that are experiencing chronic sleep deprivation and we look at what sleep debt they have accumulated, there's really no accurate way to quantify and put a number to that. And that's what I like to explain to my patients that come into the sleep lab. Their sleep issue has been probably something they've been experiencing for months, if not years. Sometimes it's a lifetime, and they're finally coming into the sleep lab to get treatment. And so not to be discouraged if they don't feel immediate relief the next day, because it could take a while for their body to finally kind of recoup the sleep that they've lost and recover from the sleep debt that they have created, or not they've created, but that has been growing in their life. So sleepiness is subjective. Some people, like I said, are able to tolerate it and are able to, not really complain too much about being tired despite having a pretty significant sleep debt accumulated. And some people can have, a very modest or mild sleep deprivation, but feel really, really feel the effects of it. So it's all subjective. What we want to look at when we bring a patient into the sleep lab is the clinical significance. So how long has it been going on? Something that's been more long-standing is obviously a little more serious of something that's just, it's just been this last week that I've been having issues. And how reversible is it? Is there anything that brings them relief? Is there anything that alleviates or aggravates their issue that they're coming in with? So is it something that we can take care of for them and help them with to work towards finding some relief? So when we assess our patients, we assess their history. And we have them take a lot of these subjective introspective assessments, which is kind of a fancy way of saying we give them a bunch of questionnaires that have them examine themselves and how their sleepiness has impacted their life, has impacted, their functioning and their health, and all different aspects of their day-to-day process. So when we have a patient and we take their history, we look at their behavior observation, and that could be their self-observations concerning past events or reports from family and friends. Usually there's a sleep history interview, and that's usually done with the physician during the initial office visit, where they get their history from not only them, but hopefully also from their partner or their spouse, because they may complain of this patient snoring or not breathing at times during sleep, whereas the patient might themselves be unaware of certain issues. We want to look at how often they have unintentional sleep, because that's a really good indicator of how tired somebody is when they can't stay awake in the car, or when they're a passenger in the car, or when they're sitting watching TV, when they don't intend to sleep but they find themselves sleeping. That's a really strong signifier that this person is really tired. Yeah, so we just try to really determine the overall severity of the problem, get the patient's take on it. Um, we try to do that by asking appropriate questions, but not just asking questions that you have no understanding of, understanding the answers. And that's what the process of what we'll be doing throughout the course of this curriculum is, kind of really learning the ins and outs of sleep. So when you ask patients these questions, you have some understanding of the answers to be able to then kind of, further the questioning and also further your recommendations or your help for the patient. State the questions clearly, use simple language. We try not to talk above your patient. The point is not to prove how smart you are by saying how big of words that you know, but to actually put it in a way that they understand that you're going to get an honest answer back as well. So asking questions that are appropriate to the patient's age, their abilities, their medical disorder. Make sure that they know that you're really just gathering information for their overall health and assessment. You're not there because you want to know, you're being nosy, or are asking questions that aren't necessary, anything like that. And we never evaluate, judge, or diagnose the patient. Evaluation and judging the patient, that's moral and also just, clinically. It's not within our scope of practice to give a diagnosis. That has to come from a physician. So we have to be very careful with how we give information to our patients. Like, for instance, if I'm explaining obstructive sleep apnea to them, I can utilize their health history that they have to kind of put it in perspective to how it might be present in their life. But I'm usually try to be a lot more kind of generalized in my explanation. So instead of saying you have obstructive sleep apnea and this is why and this is why and this is why, just, more general, I'm like, okay, I want to just explain to you what obstructive sleep apnea is, and this is why we're asking these questions, because sometimes these can be symptoms of it, or give us an idea that you might have to give us, so you have to be very careful with how you word things. And I promise you, some people speaking to a patient can become very natural, very easy. A lot of people it's not, and it wasn't that way for me either. And it's through a process of just continuing to practice that you get to a point where you're able to adequately communicate to the patient and not do it in a way that you're giving too much information, too little information. I'm sure you've probably all been in a situation too where you're at a doctor's office and they say something and it incites fear, like, oh my goodness, what are you trying to say? And it's like, oh, no, that's not what I meant. So there's a fine line, and it's a delicate art form, being able to get to be able to adequately communicate to the patient. Take the time to make the patient feel relaxed, comfortable, familiar with their surroundings, with the sleep lab. It helps them become more confident in you and your abilities. If the patient is unable to give you accurate info, you might be able to ask whoever's accompanying them. And if no one's available, you might have to consult the patient's medical chart, the referring physician. But a good open-ended question would be to ask them what kind of problems brought you into the sleep lab today. Because again, we want to try to ask yes/no questions, that type of thing. So in the chart, what you'll find a lot of introspective measures, which are these questionnaires. And when we have the patient and we give these introspective measures or these questionnaires to the patients, they're answering it, and it's based on their how they perceive their symptoms to be. Now, it can also be easily faked. It's important to remember that these questionnaires and all these measures that we use, they're subjective. They are not to base the patient's diagnosis on. We're not, it's not the end all be all. They're really just to help us better kind of explain and describe what's going on with the patient, because they can easily be faked in a positive or negative description, or positive or negative direction. So we're mainly using them for description. We're not using them to create or establish a diagnosis. So one of the things that you'll see that a patient might keep is, we'll ask them to keep a sleep diary, which is essentially a log kept over a period of about 1 to 2 weeks, where we have the patient record what time they went to bed, what time they wake up, how much sleep they felt like they got, how many times they woke up during the night, how alert they felt. There's a lot of different versions of these sleep diaries. Some have the patient record caffeine. Some of them have them record medications, naps, anything like that. And it's really just to give us an idea of the patient's sleep period. Do they maintain a fairly consistent schedule over the course of the week? Or is their sleep period really all over the place? Are they giving themselves an adequate amount of time to fall asleep and to be asleep? Or are they creating this kind of scenario where they are creating this sleep deprivation? So it's really just to give us an idea of their sleep kind of schedule over the course of a week or two, however long the patient keeps this sleep diary. Other questionnaires that we give the patient are we have the Epworth, the Berlin, Stanford, the PSQI, and the Stop Bang. And again, giving the patients all these questionnaires to fill out, they're all reliant on the patient being honest. Some of these questionnaires only identify daytime sleepiness. They look to see how tired a patient might be and how it might impact their life or how severe their sleepiness is. Some of them look to try to find, some of these questionnaires are looking to try to find what the cause of sleepiness might be. But the ones that identify just the daytime sleepiness, which would be like your Epworth, they operate under the theory that if a patient is really tired, they may have a treatable sleep disorder that in all likelihood needs further investigation. So there's a lot of good information that stands to be gained from these questionnaires. Some of these are used more often. Some of them are a little bit older and have kind of fallen out of the wayside, but it's important that you know all the different questionnaires that we are giving to the patient. So the Epworth is basically you give the patient a bunch of circumstances and they rate the likelihood that they would fall asleep in those situations on a 0 to 3 scale. So 0 being no chance of dozing, 3 being a high chance of falling asleep, 1, 2 being somewhere in the middle. And then their overall score would be where they fall on their level of daytime sleepiness. So here's the different scenarios, whether when they're sitting or reading, rated on a 0 to 3 scale, when they're watching TV, sitting inactive in a public place, being the passenger in a car, lying down in the afternoon, sitting and talking to someone, sitting quietly after lunch, stopped in traffic for a few minutes. So that would be like, for instance, stopped at a red light. Obviously, some of these are a little more severe than others. So if the patient set gave stopped in traffic for you, even just a 1 or a 2, like, yeah, I would be a little more concerned about that than somebody rating that they would all likelihood fall asleep lying down in the afternoon. So you also have to kind of evaluate where they put and rate these different scenarios in terms of severity. So if you go through the Epworth, and you're going to get a packet of all these questionnaires. I'm going to give them all to you so you guys can evaluate yourself and kind of see what's your score, where you fall in this kind of scale in terms of how tired are you throughout the day. The Stanford Sleepiness Scale is a visual analog scale, which basically means, so, if you ever go in the hospital or something and they give you this scale and it's a bunch of smiley faces and they ask you to point on the sliding scale of smiley faces where your pain is. The Stanford Sleepiness Scale is very similar to that pain scale, but just in terms of how awake or alert you feel at that very moment. So it only identifies when a patient is sleepy and their level of sleepiness at that particular moment that they're given that specific scale. So that's why it's not really great on questionnaires that we send home with the patient, because it's really asking them, how tired are you right now while you're completing this questionnaire at this kind of ambiguous time. But instead we'll use it when they come into the sleep lab. So when the patient first arrives, before they go to bed, we give them a pre-sleep questionnaire. It's a good, the Stanford Sleepiness Scale, you'll usually find it on that. We're about ready to start your sleep test. How tired do you feel at this moment? And it's usually used on post-sleep study questionnaires. So like in the morning, the patient has to fill out a questionnaire about their night, and you'll usually see this Stanford Sleepiness Scale on that as well. Like, okay, we just did your sleep study. You just slept all night. At this moment, as you're filling out this final paperwork, how awake or alert do you feel? So that's the Stanford Sleepiness Scale, 1 being wide awake, 7 being pretty much very difficult to stay awake, kind of looking at where you are. I could give you the Stanford Sleepiness Scale now after listening to me for 25 minutes, how you feel, but I don't think I really want to know. The Pittsburgh Sleep Quality Index, or the PSQI, it's a very in-depth questionnaire that has asked the patient to rate their sleep over about a 1 month period. So the PSQI is a very in-depth questionnaire. It looks at their quality of sleep, the different types of sleep disturbances they experience, whereas both the Epworth and the Stanford really only look at how tired are you, what's your level of daytime sleepiness. The PSQI really looks at how long the patient's sleeping for, how long it takes them to fall asleep, what their overall quality of sleep is, what their sleep efficiency is, which means how much time are they spending asleep compared to how much time are they spending in bed. So are they spending a lot of time in bed and they're not really sleeping? Are they pretty much, as soon as their head hits the pillow, they're out, and as soon as that alarm goes up, they're up? What could be potentially disturbing their sleep, what medications they're taking, daytime dysfunction, how their sleepiness is impacting their day-to-day activities. So this is a very in-depth questionnaire. Most labs give their own variation of the PSQI to patients to kind of to start the paperwork for to establish themselves at a sleep lab. So when a patient walks into a sleep lab or starts, getting under or goes under the care of a sleep physician, they're given a lot of paperwork and a lot of questionnaires, and each lab has come up with their own version of a questionnaire, but it's usually a variation of a lot of what the PSQI entails, to just be able to better kind of pinpoint what the patient's sleep issue is and where we might need to go with testing, and to better further kind of individualize testing and care for that particular patient based on what they're reporting, their symptoms are, their issues are, all of that. Some of the other questionnaires only look for certain disorders, specifically obstructive sleep apnea, and that's the Berlin questionnaire and the Stop Bang. So just to give a quick review of what OSA is, obstructive sleep apnea is when the airway closes off on itself. So when we fall asleep, our muscles relax. That includes the muscles of the upper airway, and that's really all that we have holding our upper airway open is muscles. So when those muscles relax, it can cause the collapsation of the airway, thereby obstructing the airway, see, obstructive, and preventing a person from being able to breathe. An apnea, by definition, has to last at least 10 seconds, and then the patient, that their oxygen levels drop, their CO2 levels rise, they have that struggle to breathe. As their airways closed up, they eventually wake themselves up. So that's kind of the cycle of what happens with obstructive sleep apnea. Is we fall asleep, those muscles relax, the airway collapses, which results in the apnea, the oxygen levels drop, CO2 levels rise, hypoxia, hypercapnia. You have this struggle to breathe, which ultimately results in the patient waking up from sleep. When they're awake, the muscle tone is restored. So their muscle tension is back at wake levels. So their airway opens and they're able to breathe again. And oftentimes you see a little bit of hyperventilation because they're trying to bring back up their oxygen levels and blow off the CO2 that accumulated. They fall back asleep, and it can keep happening over and over again. It's a pretty nasty cycle. When we look at our patients for OSA, there are certain risk factors. Obesity is a big one because, where people gain weight can impact their airway. Whatever is going to make the airway a little more narrow. And so weight, depending on where it's held, especially if it's held more trunkily versus evenly distributed on a person's body. But also when we gain weight, we can gain it in places that you can't really see. And that includes the soft tissues of the upper airway. So it can make the airway more narrow in that regard. Anatomy has a lot to do with OSA as well. So that includes the Mallampati score, which is basically looking at a person's airway and the amount of visible structures that the person has. So Mallampati class in 3 and 4 have a fairly more narrowed airway. So it means that they are anatomically more predisposed to having obstructive sleep apnea. Men are more at risk than females. Part of it is because of the way men are built. Their neck size is bigger, their neck size tends to be longer as well, and just where men tend to carry weight. Age, as you get older, everything gets floppier, and that includes the muscles of the upper airway. Family history kind of really does point towards an anatomical predisposition. Reflux is one of those things. What came first, chicken or the egg? So somebody can have obstructive sleep apnea and it can cause their reflux to be significantly worse, because when you are trying to breathe against an occluded airway, that struggle to breathe can cause that acid to kind of work its way up the esophagus. But also somebody that has reflux can make them more predisposed to having OSA, because depending on how severe their reflux is, that acid can kind of corrode the integrity of the airway. Hypertension. Hypertension is one of those things with obstructive sleep apnea. You'll notice it on all the questionnaires that hypertension and OSA just go hand in hand. High blood pressure, OSA. And it's found to be an independent risk factor. That's how much they are connected. So just obstructive sleep apnea alone can make somebody more at risk to having hypertension, but because hypertension is just so common in patients with OSA, having it makes them more at risk for OSA. The large tonsils, large tongue, small jawbone, nasal obstructions, this all kind of points towards a more narrowed airway. Anatomically, having a more narrowed airway, and that's all going to make a person more at risk for sleep apnea. So consequences of untreated sleep apnea, we talked about the daytime sleepiness component. These patients are going to be tired because not only are they not getting enough sleep, but the sleep they're getting is going to be a lot poorer quality than what we would see in somebody that doesn't have sleep apnea. So they've got all the same kind of symptoms and issues that we can see in patients that suffer from excessive daytime sleepiness in some other regard. And we already talked about that, so I'm not going to spend too much time on this here. But physiologically, untreated sleep apnea can put a lot of stress and strain on the body, and more specifically the heart. Because when you're asleep, that's when your body and your heart, the heart is a muscle that's working constantly. But when you're asleep, the heart gets a little bit of a break, or it should be anyway. But when somebody has obstructive sleep apnea, they're in essence getting choked every however often it's happening throughout the night. And so your body and your autonomic nervous system, it stays in that fight or flight kind of mode, because it's essentially like somebody's coming and strangling you for at least 10 seconds periodically, repeatedly throughout the night. So that kind of stress response is elevated, and one of the reasons why high blood pressure is an issue. The heart is working a lot harder, so having heart failure, irregular heartbeats, patients are a lot more of risk of heart attack and stroke. Diabetes is another one that they found to be very correlated to obstructive sleep apnea, and namely the cornerstone of diabetes, which is insulin resistance. What happens with diabetes is the body can't process sugar correctly, and insulin is the hormone that is released to help the tissues utilize the sugars that are circulating in the bloodstream. Insulin resistance means that the tissues are resistant to utilizing the insulin. So these sugars, instead of leaving the bloodstream to be utilized as energy by the tissues, they keep circulating throughout the body. So the pancreas keeps releasing more insulin in order to try to lower the sugar levels after you've eaten or drank something very sugary or carb heavy. So that's kind of the cornerstone of diabetes, and they found that untreated sleep apnea can significantly worsen the disease pathology of diabetes and make a person's diabetes and insulin resistance a lot harder to control. Same thing with high blood pressure. So because it's kind of like the trifecta, getting if somebody does have high blood pressure, diabetes, if they have, testing them and getting them treated for sleep apnea is going to significantly improve their disease outcomes for their diabetes and high blood pressure. And it's going to make treatment of those other disorders go a lot smoother and be a lot more effective once their sleep apnea is also under control. Worsening of ADHD, we talked about all the different cognitive issues of sleep deprivation and being tired. It really can play a role mentally on especially like ADHD, and just it overall increases a person's morbidity and mortality. They're more at risk for a lot of other diseases, increased health care utilization. It's not great. So understanding the risk factors, what puts a person more at risk for OSA, and it's one of the things that you'll start to, we're going to cover it a lot, and you'll be able to start kind of picking out those patients that are more at risk so that we can, hopefully get them treated. So there's a couple questionnaires that are designed to only identify the patient's risk of obstructive sleep apnea. And the reason for that is because OSA is probably the most common disorder that we do see in the sleep lab. So the Berlin questionnaire only identifies a person's risk for OSA. It can be kind of complicated to score. It is one of the questionnaires I do give you guys in your packet of questionnaires to do, so you can see that it's not the easiest. There's three different categories that it asks you questions on that relate to your risk of OSA, which is your snoring, your daytime sleepiness, your hypertension, and your high risk if two or more of those categories have a positive score, low risk if 0 or 1 of those categories have a positive score. So because of the Berlin questionnaire, the thought process behind it is good. We need a questionnaire that identifies a person's risk for OSA, and we know what the risk factors are, but in response to the kind of the complicated layout of the Berlin, that's why somebody came up with the stop bang, which is a very simple questionnaire that is 8 questions, and it's just yes no answers, and you look at how many yes answers you have, and 3 or more yes answers means that the person's high risk for OSA. Less than 3 yes answers means they're low risk, not that they're no risk at all, just low risk. And it's just a simple questionnaire that's used to determine a person's risk for OSA. So you're going to see the stop bang used quite often. Stop bang, you're probably like, why is it called the stop bang? But let's take a look at what the questions are. Do you snore loudly, louder than talking or loud enough to be heard through closed doors? Do you often feel tired, fatigued, sleepy during the daytime? Has anyone observed you stop breathing during your sleep? Do you have or are you being treated for high blood pressure? Is your BMI more than 35? Are you more than 50 years of age? Is the neck circumference larger than 17 inches in a male or 16 inches in a female? And are you a male? Because men are more at risk for OSA. So it's asking all these questions that look at, the first 3 are looking more at the symptomology of OSA, and, 4 through 8 are looking at more of the physiology that puts a patient at risk. Have you figured out why it's called the stop bang? It's pretty simple once you get it. Each of these letters corresponds to one of the questions, and it goes in order. So snoring, tired, observations. So has anybody observed you stopping breathing? Pressure, blood pressure, BMI, age, neck size, gender. Get it? Health history. So what we look at when we are kind of overall looking through a patient's chart, you want to look at their demographics, how old they are, their gender, what their occupation is. Occupation is important because it gives us an idea of the patient's stress level, of their schedule. Do they have a normal schedule? Are their schedule all over the place? Anything like that. Marital status. Do they have a bed partner that can give us information on like what their sleep history is? Oftentimes too, it can kind of pinpoint and point towards their stress level, because they've done studies, and patients that are divorced tend to have a lot higher of a stress level than patients that are married. what their medical history is. So things that might not seemingly be related, childhood diseases, they all can give us a really good idea of what might be going on with the patient, especially illnesses, hospitalizations. It can all impact how the study that we're doing on the patient and their course of treatment. We want to look at their family history. Does it run in families, whatever their issue is? Their emotional history. Are they stressed? Are they satisfied with life? Do they have a healthy relationship? Looking at their social history. What do they do for recreation? What their living arrangements are? Habits that includes alcohol, smoking, if they have a history of substance abuse, their travel history. I mean, it used to be we'd every now and again would get this disorder and you'd have to look, did you travel to this country or that country? And now obviously travel history, as you guys know, with COVID, it gives us a lot of good information. We need to know when the person traveled, where they might have traveled to determine their susceptibility to certain diseases, or their exposure potentially. In terms of habits, we want to look at how much alcohol they're drinking, caffeine, diet, exercise, nicotine, what their sleep habits are, what time they typically go to bed, what their bedtime routine looks like. Do they have a pet in the bed? Do they just watch TV all night? Are they, drinking coffee up until the late evening hours? And their illicit drug use. You want to look at, is this a reliable source of information that you're getting from this patient when you're asking these questions? So like a good example of this would be if you're asking a teenager if they drink alcohol or smoke cigarettes or use illicit drugs and their parent is in the room with them, do you think you're getting an honest answer? So, kind of look at all of that. And again, regardless of the answers, it's more about knowing the data and having an honest kind of evaluation of the patient's overall health, rather than, we're not here to judge. Whatever you do, it's on you. It's your life. So, making sure that when we do get this information, it's just that. It's information that helps us help the patient find answers to whatever their issue is that's bringing them to the sleep lab. We want to look at what their chief complaint is, why they want a sleep study, when it started, if there's anything that aggravates or makes their sleep issue worse or makes it better. When did their sleep problem begin? How often does it occur? Are they taking any medications for it, or have they taken any medications for their sleep in the past? What was the outcome? Did it help? Is the patient awake or aware of their issue when it occurs? Or are they coming to the sleep lab because they've been told about the issue? We do get a lot of patients that will come to the sleep lab because their spouse is forcing them and they're simply doing it to appease their spouse. Ask my husband. That's the only reason he followed through with the sleep study, is because I nagged him until he did. And we get a lot of that. A lot of these patients that don't really think they have an issue, but the people that they live with see it and, kind of push them towards getting answers. So when we go through the chart, first thing we've got to do is we've got to check the physician order form and check all the different components of the order form to make sure it's a valid order. If not, we can't do the test. We do everything under the direction of a physician. That's what our scope of practice is we work under a medical director. We work under a physician. And so, we're not the ones determining the tests being done, but we certainly can help guide the physicians. They see a lot of patients in the day-to-day. So making sure that we have a valid physician order, that it's signed, that whatever study is ordered that we're going to be doing for the patient, any special precautions or instructions. And then what we need to do is do our due diligence and verifying that info, going through the patient's chart, reading through all the notes, their questionnaires, and making sure that the correct test is being performed. The physician might miss some things that are a component that, we might want to bring to their attention. after reviewing, looking at what they ordered, and hey, you can always within our scope to call the physician and say, I saw that you ordered this study for the patient. After talking to the patient or reviewing this questionnaire, this came to light. Do you want me to add in this additional testing parameter? We have that ability. We just need to do our due diligence in reviewing the patient's charts thoroughly. The other component of it is charting. You can never chart enough information. And you'll hear me say this time and time again, is if you did not document something, it did not happen. So it's so important to chart and document everything, especially when what you communicate with the patient. If you gather more information beyond what is in the chart, what you were able to read in the chart, the patient opens up to you about something and anything like that, you've got to document it. Documentation is, there's two things. As we get to know each other more, as you continue your curriculum in sleep, there are two things that I really, really kind of are my hang-ups. One of them is patient education and communicating to the patient and making sure that we utilize the time we have with them to make sure they're experienced and they're educated and informed. And the second is documentation and making sure that our documentation is on point. I'm not going to spend too much time on documentation here because we have a whole other talk on it. Before the patient comes for the sleep study, though, what we want to know is why they're coming, if there's any special needs for the patient. So for instance, like, on the order form, we will go through, the physician can request certain additional safety parameters, but it's also within our scope of practice or within our, honestly, it's our responsibility to add in any extra safety parameters that we feel necessary, whether or not it's part of the order. And that could be either fall precautions, making sure the patient doesn't fall while they're in your care, make sure they don't fall out of bed, things like that. What their medications are, because as we continue through pharmacology, you'll see that every medication has the ability to impact sleep. So knowing what the patient's taking and, the schedule of their medications when they're taking it, what their alcohol, caffeine intake is, what their normal sleep schedule is, and then their basic set of vital signs. It is our responsibility to review the patient's sleep history before beginning the study. So the patients, while they're in our care, they're our responsibility. Their safety is our responsibility. And we're able to make sure that our patient is the most safe by doing our due diligence and evaluating the patient appropriately through, the evaluation of vital signs, but also evaluating their chart fully and finding all the different things that could potentially be a safety issue or a risk factor or anything like that. So fall precautions, basically you're flagging anybody that is at a greater risk of falling. And so if somebody's had a history of falls, you'll notice that in the questionnaire oftentimes that asks, have you fallen within the last 3 months? I don't care if it was because you stepped on a patch of ice. If you fell and you have a history of falling, you're a fall risk. If they used any type of walking assistant device, so a walker, a cane, wheelchair, anything like that. The elderly, anybody that has a history of difficulty walking, regardless of whatever it is. And there are other comorbidities or medications that can put a person more at risk. So medications, especially I want you thinking like the sedatives, the really strong pain medications or analgesics. For comorbidities, there's a lot of different things that could put a person more at risk. So as you continue to and start to practice reviewing and going through a chart, if you come across something that you don't know, look it up. Fibromyalgia, diabetes, like all these different things that a patient could have, look up what it is so you understand it. And, the next time you come across it, you'll be more familiar and understanding like, oh, you know what? This patient could be a fall risk because they have this disease or disorder. As you continue to practice going through charts, you'll be able to recognize where to find indicators for why a patient might need fall precautions. Whether it be where you find the question if they fell before, but also, okay, where's their medications? Where's their history? Make sure you go through it all. and what we're going to do for these patients. So just saying a person is a fall risk, I'm going to employ fall precautions. Well, that doesn't really do anything if you're not going to follow that up with actions. So if necessary, put in bed rails. Not every fall risk needs bed rails, so I will say that. Only patients that are at risk of falling out of bed, but making sure that there's lights in the hallways so they can see when they're walking. There's nothing in the hallway for them to trip over. If necessary, assist anyone at risk for falling. So walking with them, helping them stand up, helping them ambulate to and from the bed from a chair or whatever. Bed rails are utilized for anybody that's at risk of falling out of bed. So again, they're not necessarily a component of every fall risk, of every patient that is deemed a fall risk, only for patients that are at risk for falling out of bed. So that would be your kids, patients that have a history of seizures and epilepsy, because if they were to have a seizure during the night, they could flop out of bed while that seizure is happening. REM behavior disorder is a disorder where the patient acts out their dreams. This is somebody that could potentially fall out of bed. So we would want to put bed rails up for those patients as well. Like I said, just because a patient is a fall risk, like maybe they had knee surgery or are elderly, it doesn't automatically mean they're at risk for falling out of bed. So bed rails, basically, if you see anything like this in their chart, definitely you're going to add bed rails. But beyond that, bed rails are more added as needed. So sometimes you'll see a patient that just, I don't know, they have a hard time getting into bed and then they're right on the edge. Yeah, those patients I'm going to put up bed rails. But for the most part, most patients that are a fall risk, they don't necessarily need bed rails. Just because they're at risk of falling on the floor doesn't mean they're at risk of falling out of bed. I mean, look at yourself. When's the last time as an adult you've fallen out of bed? Other special needs we might see are patients that are morbidly obese. So they might require a special bed to help them get in and out of bed that can accommodate, their size and all that. Or they might need to sleep in a more upright position, that where that weight falls. It could be really difficult and also unsafe for them to sleep flat out. So accommodating whatever they need. A patient that has asthma. Oftentimes we see asthma can get a little bit worse at night, and a lot of that has to do with the autonomic nervous system. So it can, when a patient does have asthmatic issues at night, knowing, making sure they're able to take their medications, but also understanding that the medications do oftentimes have a stimulant effect, and just being able to make sure you document that for the sleep study. And we're going to keep going through different comorbidities throughout the course of the curriculum. But what should a technician do first to make sure the proper test is being performed? That's it for this talk. Feel free to comment on the talk if you have questions, or post in the Ask discussion board. And we'll keep going through a lot more of this and covering this in lab during the week.